Well, thank you very much for your kind invitation. Igor was always kind in communicating with me. And my topic will be therapeutic laser vision surgery. And these are my disclosures. And I will use the first couple of slides to define therapeutic laser vision surgery with respect to the elective laser surgery that we all know. Aim of the therapeutic laser vision surgery is to improve impaired vision. It means decreased quality of vision and decreased visual acuity occurring due to corneal optical irregularities. So the etiology we want to address is corneal pathology, dystrophies, post-keratitis, scars, keratoconus, and also we want to address iatrogenic conditions like corneal irregularities secondary to complicated refractive or other eye surgery or eye injuries. And our treatment is aimed to correct primarily higher order aberrations. We also may correct sphere and cylinder if it is convenient. It means if the correction requires only moderate use of stromal tissue. And the main source of surgical data are objective measurements by corneal topography, tomography, and wavefront aberrometry, while subjective refraction is used only as kind of modifying our ablation plan. And our preferred surgical technique in this situation is transepithelial topo-guided ablation or wavefront guided if reliable wavefront data is available. And there are several issues that we are dealing with in therapeutic laser refractive surgery, which we do not need to address that much in elective cases. So we have to look at the cylinder very closely because we use topography-guided ablation, how to program the cylinder. Higher order aberrations refracting a cylinder are always present there. How our treatment will affect the cylinder after we regularize the higher order aberrations, specifically odd order, coma, and trefoil. And we also have to look closely at the posterior corneal optics, especially in cases like keratoconus or post-incisional, post-RK, post-AK surgeries. And these are quite complex evaluations, and they would need a longer presentation than I have time today, so I will just skip this part for some other time. And today I will talk about the corneal epithelial remodeling, how it affects manifest refraction in cornea, in irregular corneas, and how it affects our choice of surgical technique in irregular corneas. So let us look first very shortly about the concept of epithelial remodeling. The epithelial remodeling issue has been quite a hot topic the last 5 to 10 years rather. And the main feature is that the epithelial remodeling is a process where the epithelium gets thinner above the stromal elevations and thicker above the stromal depressions. So we have this anterior elevation map of a keratoconic cornea, and when we superimpose the epithelial map of the same eye, we can see that cornea epithelial thickness map shows significant thinning over the cone, and we have some compensatory thickening around the thinning part, which is normally characterized as a donut pattern. But another thing that not everybody is considering, but which is very important, is that the epithelial remodeling is not linear. it is inversely proportional to the sharpness of the irregularities. So more irregular cornea, the more epithelial remodeling will happen. So in this case on figure A, we have a sharp dents and sharp spikes, and the epithelium, which has been stimulated 100% to remodel the irregularities 100%. And in this case, we will have normal topography because the anterior surface does not show the stromal irregularities underneath. And but if we look at the epithelial thickness map, it will be showing us thinning over the spikes and thickening over the dents. The opposite situation will occur if we have very smooth transitions between elevations and depressions. So in this case, epithelial remodeling will not be stimulated. It will not happen. Epithelial will not, I can say, know that there is something irregular on the stroma because it's a very smooth transition between the irregularities, which may be optically significant, but epithelium would not do anything without it. So it would be 0% remodeling. We will have still irregular topography, but we will have normal epithelial thickness map because epithelium will be of even thickness over the whole cornea. So our research group was very, very interested in the epithelial thickness mapping and different consequences, and we wanted to find out how much refractive-wise epithelial remodeling can contribute. So we look at a certain number of eyes at the topographies before the epithelial removal, just normal corneal topographies, and we took the corneal topography after the epithelial removal. And in this case, we looked first at curvature, and we can see that steep K was increased from 14 diopters to 50.31 diopters after epithelial removal. So it was 4 diopters in difference, very significant. If we look at the astigmatism, interesting thing happens also there. Like we have actually less astigmatism on the stroma than on the epithelially covered surface. And it is because this significant coma on the stromal surface will be remodeled and will fit into astigmatism on the anterior surface. So we have astigmatism which increased from -28 to 128. And but this is due to the coma, and we will soon see on the next level when we consider the ray tracing power that asphericity increased significantly from -87 to -2.14. And while high order aberration, that is this coma coming in, was increased with epithelial removal from 296 micrometers to 447 micrometers. So all these changes are due to this epithelial, we can call it epithelial lenticule, which is a concave epithelial lenticule with 39 microns thick in the center and some 70-80 microns thick in the periphery. And some generally then epithelial remodeling reduces stromal steepness and asphericity and smoothens the stromal irregularities. And that is why we often say epithelial is our friend. And we will look at this statement a little bit later on. So let us look, how does the epithelial remodeling affect the outcomes of different surface ablation procedures? We looked also in this issue and some publication. And let us look what is happening if we do PRK on irregular astigmatism using topo-guided PRK. So we first take a topography, normally with epithelium on, and we design our topography guided ablation plan. Then we remove epithelium with alcohol or mechanically, and then we can immediately see that our surface is now totally different than it was before the removal of epithelium. So the red line on top of the epithelium has much less peak to valley distance than the stromal surface, significantly higher peak to valley distance. So when we remove the epithelium, we get a new surface, which our topography guided topography did not register, and our topography guided ablation plan based on that topography will not now fit to the new circumstances when the epithelium is removed. So it will only partially reduce the irregularity. And why is that? It's because we have thrown away the action of the epithelial remodeling, which was smoothening the cornea already. So we have thrown away the natural smoothing of the cornea and now only applied our topo-guided ablation, which only partially can reduce the irregularity. So what we could do then? Our solution would be transepithelial PTK for epithelial and partial stromal removal, plus anterior topography-based topo-guided ablation, which nowadays is very prevalent in most of the laser as topo-guided transepithelial PRK. So, we measure topography with epithelium on like before and design our topo-guided custom ablation plan but instead of removing the epithelium by alcohol or mechanically, we do program PTK, transepithelial PTK with a thickness based on the thickest point of the epithelium. That way, our ablation will consist of all the epithelium, which is in yellow, and the strong protruding stroma, which was remodeled by the epithelium in our striped area. So when all this is removed without transepithelial PTK, we will get stroma that resembles the landscape of the cornea with the epithelium on. And when we apply our topo-guided custom ablation plan based on topography as measured preoperatively, we will, at least in theory, get the totally regularized cornea. So, topo-guided ablation in the treatment of irregular cornea. Epithelial remodeling smoothens the irregularities of the stromal surface and improves the corneal optics. But normally it is not enough. That's why we get the patient. And if we have to treat this patient with topography-guided custom ablation, we must follow the rule to always ablate the very same surface from which the topo-guided ablation data originates. It means if we have anterior topography-guided PRK, that must be applied directly on the epithelial surface because our topography was taken with the epithelial on. So it's a transepithelial topo-guided PRK. If we can program our topo-guided ablation on stromal topography, then we would be able to remove the epithelium and apply it on the stroma. Yes, this was the things, I think that my time is up, and this is what I wanted to show, and I thank you for your kind attention.
Dear Alex, thank you very much for your lecture. We have two short questions. First is about wet PTK. Do you use wet PTK? And if yes, what is the masking fluid you usually used in your procedures?
Okay. I do wet PTK in some special circumstances, not this case. This is just the transepithelial PTK. This is the epithelium is our masking agent, right? But in a case where I have, for example, after removal of the epithelium of the with the wrinkles of the flap, then I may use I use wet PTK. Then I will use yeah, depending. I try and get many different options. Some artificial, thick artificial, viscose artificial tears, but I even use the just BSS and monitored. But it's very important that we monitor our PTK, not just decide some thickness and we're finished. We just have to see all the time on the microscope what we're doing. Are our irregularities getting smoother? Are our strias disappearing or not? So this is.
Thank you. Thank you. And one short question about elective procedures, not therapeutic. In everyday practice, difference between PRK and LASIK regarding biomechanical stability. What is your opinion?
Yeah,
In few words.
well, my opinion is based on everybody else's opinion, which is that PRK best preserves the corneal biomechanical strength, and even better than SMILE procedures. So it's still the safest procedure if we want to be sure that we do not affect the biomechanical stability of the cornea.
Dear Alex, thank you very much. We're so honored to have you with us today. Hopefully next year you will come here and we will
I would
see
like
you,
that
not
very
just
much.
hear you.
I just get enough in advance, so I will do everything to come. Thank you very much.
Thank you very much. We keep in touch. Doviđenja.
Hvala, doviđenja.
Mijenjamo, samo mi smo mutali, mijenjamo dvoranu, silazimo u dvoranu.